A woman develops mania for the first time in her life, in her late 40s. No psychiatric history, no obvious cause. And the answer, when it finally came, pointed straight at perimenopause. That case study landed in my queue this week and I haven't stopped thinking about it. Stick around.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a genuinely interesting mix today, one that got heavier as the week went on, honestly. So let's get into it. The first thing I want to talk about is a case study published this month in PubMed by a researcher named Nathani. The title is From Perimenopause to Neuroinflammation, Rethinking a Case of Late-Onset Mania. And I want to be upfront about what it is. A single case report, not a randomized trial, not even a cohort study. One patient. But the framing matters, and it's the framing I want to talk about. The case centers on a woman who develops mania for the first time in her late 40s. No prior psychiatric history. The symptoms look textbook acute psychiatric. Elevated mood, reduced sleep need, pressured speech, impulsivity, the full picture. And the initial clinical response is what you'd expect. Psychiatric evaluation, mood stabilizers, the mental health pathway. What the case report argues, and this is the part worth sitting with, is that the actual driver was neuroinflammation, and that the neuroinflammation was triggered by the hormonal upheaval of perimenopause. The mechanism being proposed is that estrogen fluctuation during perimenopause can dysregulate neuroinflammatory pathways. Estrogen has well-documented anti-inflammatory effects in the brain. When those levels start swinging, and in perimenopause, they're not declining smoothly, they're lurching. You can get inflammatory signaling in the central nervous system that doesn't look like a hot flash. It looks like a psychiatric event. Now, I want to be careful here because this is one case and one researcher's interpretation. The evidence base for perimenopause causes mania via neuroinflammation is not settled science. It's a hypothesis with biological plausibility and, frankly, not enough clinical attention. What the paper is really doing is raising a flag. When a woman in her late 40s or early 50s presents with first episode mania, is anyone asking about her menstrual cycle? Is anyone ordering hormone panels? Is anyone even thinking about perimenopause? And the answer, based on what we know about how psychiatry and general medicine are trained, is mostly no. The average physician gets around an hour of menopause-specific training in medical school. 1 hour. So the woman in this case report lands in a psychiatric workup, which is appropriate, but the possibility that her hormonal transition is the root of what's happening doesn't make it into the differential until much later. That delay has consequences, not just for treatment, but for how a woman understands what's happening to her. Being told you have a new-onset bipolar disorder in your late 40s, and then discovering years later that perimenopause may have been the precipitant. Those are two very different experiences of your own health. This is why I think case reports like this one matter, even when they're not statistically powered to prove anything. They're a prompt. They're a clinician saying, look over here. We may be misclassifying a cohort of perimenopausal women as primary psychiatric cases when the hormonal axis is doing something significant. That's worth investigating at scale. The tools exist. The will to fund it is the missing variable. The second paper this week is from a researcher named Salman, also June 2026, and the title is almost a mouthful. Do stretch sensors expressed by aortic baroreceptors interact with circulating estradiol to mediate baroreflex sensitivity in hypertension? What that's asking, in plain language, is whether estrogen affects the pressure sensing machinery in your aorta, and whether that's part of why blood pressure regulation changes after menopause. Your aortic baroreceptors are essentially stretch receptors in your aorta, a major artery that monitor blood pressure in real time and signal your nervous system to adjust heart rate and vessel tone accordingly. This is your baroreflex. It's one of the main systems your body uses to keep blood pressure stable when you stand up, when you exercise, when you're stressed. It's not optional infrastructure. What this paper is exploring is whether estradiol, the primary form of estrogen, actually interacts with the molecular sensors in those receptors. And the implication is significant. If estrogen is part of what keeps that system calibrated, then losing it isn't just about your bones and your brain. Your blood pressure regulation itself may become less precise. We already know that cardiovascular risk rises meaningfully after menopause, and that the timing of HRT relative to menopause onset seems to matter for cardiovascular outcomes. The timing hypothesis has decent supporting evidence. But the conversation about why postmenopausal women have higher rates of hypertension often defaults to lifestyle, weight changes, stress, aging in general. What this line of research is suggesting is that there's a more direct hormonal mechanism operating at the level of the vessels themselves. The hardware changes when estrogen leaves. I'll be honest that this paper is asking a mechanistic question. It's not a large clinical trial showing that HRT lowers blood pressure in a specific population. The science is upstream of clinical recommendation. But it's the kind of upstream finding that, when it replicates and builds, eventually changes how we think about prescribing. The sort of thing a clinician would track on a tool like Open Evidence, watching for when the mechanistic picture firms up enough to change practice. If you have a family history of hypertension, or if your blood pressure has been creeping up in the last few years, this is a reasonable thing to bring to your doctor. Not as I read a study, but as I know cardiovascular risk increases post-menopause. Can we talk about what we're watching for and what we do about it? The third paper this week is the one I want to be most careful with because it touches breast cancer, and I never want to sensationalize in this space. The study is by HEP, also June 2026, and it's a retrospective analysis of risk factors and prognosis in something called infiltrating micropapillary carcinoma of the breast, IMPC. IMPC is rare. It makes up somewhere between 1 and 2% of all breast cancers. It's worth knowing about, not because it's common, but because it behaves differently from the breast cancers most women have heard about. It tends to present at higher grade. It has notably higher rates of lymph node involvement. And in this retrospective cohort, those factors translated to distinct prognostic patterns that set it apart from the more common invasive ductal carcinoma. A retrospective study has limitations. It's looking back at existing records, not following patients prospectively. So there are confounders and selection effects you can't fully control for. But in a rare cancer subtype, retrospective data is often what you have to work with because recruiting enough patients for a prospective trial takes decades. You use the data you can gather. This is where the evidence base starts. The relevance to this show is indirect but real. Postmenopausal status and hormone receptor expression are part of the risk factor landscape the paper examines. That puts it in territory this audience cares about. And I think women deserve to know that not all breast cancers behave the same way. That rare, more aggressive subtypes exist. That pathology matters without being handed fear as a takeaway. What a study like this does is push toward better subtype-specific treatment protocols. That's what the science is for. If you've had a breast cancer diagnosis of any kind, the conversation with your oncologist about specific subtype and what it means for your treatment plan is the conversation that matters. Not a podcast, but knowing that subtypes exist and that they're studied, that's just being informed. Thanks for spending the week with us. Genuinely, I know you've got choices when it comes to what you listen to, and I'm glad you're here. If Hot Flasher is your thing, please hit subscribe wherever you're listening so you don't miss an episode. Have a great weekend, and I'll see you Monday.
That's our week. Thanks for listening to Hot Flasher. We'll be back on Monday. Have a great weekend, everyone.